Hello and welcome to this lecture. Today we are going to discuss lung tumor, and we are presenting the case of a 50-year-old man presented to our clinic with 6-month history of worsening dyspnea on exertion. His symptoms including near constant dry cough, diminished appetite without weight loss and fatigueness. He had previously been diagnosed having diabetes with uncontrolled glucose level and hypertension, and the patient was smoker with around more than 40 packs per year history. A bronchoscopic biopsy was performed and a pathological examination confirmed the presence of small cell carcinoma based upon the immunostaining. So when we take a look on lung tumor, roughly 95% of the primary lung tumors are carcinoma, and 5% are miscellaneous groups such as fibrosarcoma, leiosarcoma, and lymphomas, and few other benign lesions. So when we take a look on details, carcinoma of the lungs, it is a most common cause related to industrial countries, because the cancer of the lungs is linked to the environmental pollutants as well, and environmental pollutants can cause lung cancers. Histologic classification of malignant epithelial lung tumor is classified into adenocarcinomas, squamous cell carcinomas, large cell carcinomas, neuroendocrine carcinomas, mixed carcinomas, and some other unusual morphological variants such as sarcomatoids, spindle cell carcinoma, and giant cell carcinomas. So what is the etiology and pathogenesis? One of the reasons that linked to the etiology of the disease is smoking related carcinomas, and it occur in a step way, like in the transformation of benign progenitor cells in the lungs into neoplastic cells possessing hallmark of cancer. So the conversion of benign progenitor cells into neoplastic cell is the key characteristic, and they are also responsible sometimes because of the mutation in TP53 tumor suppressor gene. So the genetic factors are also linked to certain kind of carcinomas of the lung. One of the reason is mutation in TP53. And we also found that the adenocarcinoma, around 10% in whites and 30% in Asian, are arising from non-smoking, and it occurred because of the activation of epidermal growth factor receptors that stimulate the pathways or the signal molecules to produce or to cause the mutation in actually especially in KARS mutation. So the strong evidence that has been found is a strong link to the cigarette smoking and less in extent to environmental carcinomas. So 90% of the cases that occur in the lungs, especially lung cancer, is linked to carcinoma because of the smokers, and they will be increased risk 60 times greater than greater in habitual heavy smokers, which is consisting of 2 packs a day for 20 years. So if a person is heavy habitual smoker, he is taking smoking 2 packs in one day for 20 years. So there will be 60 times more chances that patient will have lung cancer because of the continuous intake of the smoking or continuous smoker. So we mentioned that 90% of the lung cancers involving in the active smokers are it because of the occupational smokers such as asbestos. People that are working in construction site, they are exposed to asbestos, so they are also prone to cancer. When we take a look of morphology, we found that atypical adenomatous hyperplasia, AAH, And adenomatous carcinoma is actually usually peripherally located close to ileum. The formation of gland forming acinas will be found. Then there will be squamous cell carcinomas and large cell carcinomas and small cell carcinomas. If we take a look of atypical hyperplasia, especially atypical adenomatous hyperplasia, and the main thing is that the cells change to cuboidal, and there will be less structures. The columnar shaped structures, the columnar epithelium actually is changed to cuboidal cells. This is one of the key characteristic. The second thing that has been found that the formation or the presence of fibrosis, especially around the interstitial fibrosis, and you can see that this section, there will be the presence of the fibrosis. If you take a look of next picture on the side, on the right side, it is characterized another picture of adenomatous carcinoma, and they are talking about the presence of uh, non-invasive carcinoma, and they are more present around the alveolar septa. This dark picture, the picture that has been highlighted, this. So they are adenomatous carcinomas and more profound along the septas, and that area showing you the presence of mucinous subtype, and you can see that the cells are large in size because of the presence of mucin, and but there is no invasiveness will be found. The surrounding cells are not affected in adenomatous carcinoma. This is another picture in broader sense. If you take a look of this picture, we found that the septas or the walls are more thick, and the surrounding infrastructure is normal, but the septas are more thick because of the secretion of the mucins, and then that is responsible for adenomatous carcinoma. This is another picture of adenomatous carcinoma associated lesions, and in figure A, I already see that in this figure, we are already talking about the adenomatous carcinoma with cuboidal epithelium with mild interstitial fibrosis. So the cell structures, the epithelial change from columnar to cuboidal epithelium. That's the main thing, and the formation of fibrosis in the interstitium has been found. In picture B is actually carcinoma, talking about the mucinous carcinoma that I already discussed, that is more linked to the growth of carcinoma without invasion along the alveolar wall. And the third picture C is showing you the formation of gland forming adenomatous carcinoma, where we found a large number of glandular structure that will be appear. That is why we term as glandular forming adenomatous carcinoma. This is another picture of different kind of squamous cell carcinoma, and figure A is actually the normal epithelial cells which change to squamous cell carcinoma, which we call squamous metaplasia. Then if it see that if it's prolonged from C to D, it's changed to dysplasia, squamous dysplasia. Then if it further prevailed, then it changed to more severe dysplasia. And this is the same picture that I already discussed before, that initially we start with the carcinoma, start with the A with the normal epithelium, then it changed from squamous metaplasia in B, squamous metaplasia further changed to dysplasia, C is a dysplasia, then high grade dysplasia occur at D, and E there will be carcinoma in situ, CIS, and then at the end stage it further leads to invasive squamous cell carcinoma, where in invasive cell carcinoma it if invades to the other organelles and other tissues. This is a picture of squamous cell carcinoma, and this appear on the central mass, on the hilar mass, and you can see that these mass is invade in because squamous cell carcinoma is possible to invade, so they show you keratinization and formation of pearls. This ring-like structure actually that can be expressed is as a pearl, and then there will be the formation of uh, keratinization. So these are the pearls, the round structures, and the surrounding mass that is showing you these masses. They showing you the presence of keratinization. So the picture B is showing you the presence of pearl and then keratinization, whereas picture A is talking about the squamous cell carcinoma as a central hilar mass. What is meant by hilar mass? You need to see the anatomical structure of the lung. I'm going to see you some website, some revision, and actually you can see this structure. The central structure anatomically they are explained in terms of helium. So if the carcinoma or squamous cell carcinoma occur at the helium section, we explain in terms of the hilar mass. That is why you can see this section, the hilar section, we're talking about the central hilar mass that is invading contagious parenchyma. So obviously why we say contagious, because it prevailed to further tissues, to the other tissues, and that mass actually originate at the helium. So that is why that's squamous cell carcinoma occur. Whereas in the B section, we're talking about keratinization and the pearl formation, the ring-shaped structures. Why we say that pearl? Because it look like a pearl. We can make them as a metaphor. So when we talk about the large cell carcinomas or small cell carcinomas, we differentiate on the basis of their shape. Large cell carcinomas are big round structures. Small cell carcinomas are they having cells become so small. Large cell carcinomas are having pronounced more. The cytoplasm and nucleus ratio is high, more cytoplasm and nucleus. Whereas in small cell carcinomas, that cytoplasm is less. Then, so when we take a look of small cell carcinoma, what we found? We found the cell cytoplasm has been lost and the cells are small in size. You can see this is. Then on the left side, if you take a look of this section, we found the necrosis, and then we found small, deeply basophilic cells here. So you can see these are the basophilic cells, and then the presence of necrosis. And then we also found that the basophilic staining identify the presence of azopar defect. And azopar defect is actually given by the scientists that have determined that effect. And when we discuss azopar defect, if we're talking about the loss of the DNA, or you can say that the removal of DNA. Or in simple word, the necrotic cell with release of the nuclear DNA. As we know that small cell carcinoma, the cytoplasm has been lost, so the nucleus is present. So what happened that the release of the nuclear material from the cell, and that affect in term of disintegration, and that effect is explained in term of azopartic effect. So we are talking about in this slide that there will be presence of small basophilic cells and area around necrosis on the left side. Then we are talking about the basophil staining show the presence of encrustation by DNA. It means that the cell DNA material has been eliminated outside, or disintegration of the cell that can be explained in terms of azopartic effect. So what are the learning outcomes? So what are the learning outcomes? We discussed different classification of the carcinoma of the lung, what are the cause and pathogenesis of lung carcinoma, and understand the morphological characteristics of carcinoma. So thank you so much for today's lecture. Hope to see you again.